So in this problem, a 72-year-old female presented with acute sorry old male presented with acute retention of urine for last 6 hours. So acute retention of urine for last 6 hours. It is already written in these questions. This is acute retention, okay, for last 6 hours. Time is also given. How will you manage this case? Okay, so this is a problem cards which is available in our colleges. It is very important for our practical viva voce. Okay, so first of all, how will you manage this case? So management of this case is followed under this protocol. This protocol should be followed. First, relieve the retention. Okay, first relieve the retention, then diagnose the cause of retentions. What is the cause behind this? Okay, and then treatment the underlying cause. This is the most important thing. Actually, for undergraduate or as an intern doctor, we all have to do this much things: relieve the retention and send him to the urology department for further procedure. Actually relieve the retention and do the investigation. Then what is the cause, what is the reason for the urine retention, and send him to the urology department. Okay, so first of all, how will you relieve the retention? How will you relieve the retention? First of all, look at this. There is no history of trauma. Why this is important? Because relieve the retention by using Foley's catheter. Foley's catheter. This is the first try. First we all have to do the catheterizations, Foley's catheterizations. Okay, generally using 16 or 18 French Foley's catheter. Okay, but if there is any history of trauma, although this is not related to this case, there is no history of trauma. Okay, but if there is any history of trauma, then urinary catheterizations, that is Foley's catheterization, is contraindicated. Okay, so there is no history of trauma, so no history of urethral injury, so Foley's catheterization is not contraindicated here. But I am telling that if there is any history of trauma, then if there is any history of urethral injury, then Foley's catheterizations is contraindicated. So in urethral injury, the patient presents with blood dripping out, or blood from the meatus. Okay, blood is coming out from the meatus. Okay, meatal blood, or there may be the scrotal hematoma. This is the scrotal hematoma. Okay, so this is the history of trauma, or this is the this is something indicating towards trauma. And if trauma is there, then once again I am telling Foley's catheterizations is contraindicated. Now, specific for this case, to relieve the retention, we have to do the catheterizations. So first what you will do, first admit the patient. This is the first step. Admit the patient to relieve the retention of urine. Then check the vitals of patients. Everything is okay. Then attempt for urinary catheterizations using a Foley's catheter. Attempt for Foley's catheterizations using 16 or 14 French. This is not 16 or 18. 16 or 14 or 16 French. 14 or 16 French Foley's catheterizations. Okay. Or if it is not done by this, then if Foley's catheterization is failed, then try something hard like feeding tube. Feeding tube is also used for catheterizations, or something stiff catheter like Gibbons This is Gibbons catheter. Okay, Gibbons catheter may be used, but if this is failed, then we have to do suprapubic cystostomy and suprapubic catheterizations. So suprapubic catheterizations using Malcott's catheter. Okay, so look at this. This is the Foley's catheter, or it is, yes, this is the Foley's catheter. Okay, this is actually, this is named the 2 OAs self retaining Foley's catheter. Okay, this is one way to inflate the balloon, this to inflate this balloon, and this is the another way for urine drainage. Okay, and this is the Foley's catheter, and this is separate discussions. I will discuss about Foley's catheter in separate discussion. There is 2-way Foley's catheter, there is 3-way Foley's catheter. 3-way Foley's catheter is generally used to wash the prostate during the prostate surgery. It is used, and pink color urine may be there in prostate post operative periods. Okay, but if Foley's catheterizations through this urethra it is not done, then you have to do what? You have to do the suprapubic catheterizations. And what is this? This is the Malcott's catheter. This is the Malcott's catheter. So suprapubic catheterizations, this is the pubic symphysis, and the Foley's catheterizations via this way is not possible. It's not possible. Then you have to do suprapubic catheterizations. This is not possible, maybe due to any urethral stricture or any urethral stone or any injury at these positions. That's why the Foley's catheterization is not possible. Now you should go for suprapubic catheterizations. First incise the skin, then enter into the bladder, and then put the catheter. Yes, this is the one is the balloon catheter. You can put this balloon catheter via this port or pigtail catheter. Okay, this is the suprapubic catheterizations. Okay, so done. Next is, this is the relief of retentions. Then we have to diagnose the cause of retention and treatment, the actual specific treatment, okay, for the urinary retentions. So what are the causes of retention of urine in this old age pupil? This is very old age pupil. At this age, what are the causes of urine retention? So in this old age pupil, this is the possible viva questions, that what are the causes of the urine retention in this old age pupil? In this old age pupil, there may be BPH. There is first of all the bladder obstructions or bladder outlet obstructions. Look at this. This is the urinary bladder. Okay, this is the outlet of the bladder, and this is the urethra. Okay, and somewhere prostate is here. This is the prostate. Okay, so any enlargement of the prostate, this is the prostate, any enlargement of the prostate may obstruct the outlet of the bladder. This is the bladder. Any enlargement or in fact any inflammations of the prostate, that is prostatitis, may cause the obstruction of the tract or outflow of the bladder, okay, or outlet of the bladder. So bladder outlet obstructions may be due to benign hyperplasia, that means BPH, benign prostatic hyperplasia, or you can say hypertrophy, carcinoma prostate, prostatic abscess, or prostatitis. Already I told, any inflammation to prostate. Okay, any inflammation to prostate also can occlude this. So BPH, carcinoma prostate, prostatitis or abscess, and carcinoma bladder also obstruct. Any mass, carcinoma bladder, any mass enlarged at this region, okay, also obstruct the outlet. This is the bladder outlet. It can also obstruct the bladder outlet and may cause retention of urine. And bladder stone, yes, any bladder stone and bladder neck fibrosis or bladder neck stricture due to any previous surgery. Okay, bladder stricture at this region, stricture at this region may also cause, or narrowing of this region may also cause the retention of urine. Okay, next is the bladder neck hypertrophy of the bladder neck. These all things are the differential diagnosis of retention of urine at old age. Okay, so this is all about bladder outlet obstructions. Is there any urethral cause? Yes, there is urethral cause also. Urethral cause, that means, yeah, this is the bladder, this is the urethra, this is the bladder. So anything obstructing the urethra, like urethral stricture, that is narrowing of the urethra, or urethral stricture, that is narrowing of the urethra or urethral stricture. Next, calculus, any calculus at the urethra, any tumors at the urethra, any mass, that is tumor at the urethra, or simple urethritis that is leads to inflammation of the urethra, and that's why urethra is blocked. This much things may cause the acute urinary retention. So stricture, calculus, tumor, urethritis. Next, if the patient is under chronic treatment of anti-hyper patient is under the chronic treatment of hypertensions and using antihypertensives, prolonged antihypertensives uses, and if patient is under tricyclic antidepressants, prolonged use of tricyclic antidepressants, antihypertensive and anticholinergic, this much things, they also hampered the activity of bladder, and urine retention of urine may be there. Next, other causes: rupture of urethra followed by trauma, although there is no history of trauma. Okay, meatal stenosis of the meatus. Okay, next is the phimosis. This much things are almost local causes. Meatal stenosis, phimosis, they are the local causes. This is the penile causes. Okay, fecal impingement. Okay, any spinal injury, any post-operative complications, like most commonly the perianal operations, the any operations around the anus may leads to the incontinence, that means the urine outlet obstruction or bladder outlet obstructions, or maybe due to spinal anesthesia. This is the other causes, they are also may be responsible for your bladder outlet obstructions or acute retention of urine, more specifically acute retention of urine. Okay, so bladder outlet obstruction is the one cause of acute retention of urine. So this is the causes. So if the examiner asks you what are the causes in males for the retention of urine, in females and in infants, there are the congenital causes like posterior urethral valves, meatal stenosis, they are the causes in infants. Okay, and in females the uterine prolapse, urethral stricture, uterine or ovarian surgeries. Okay, in male BPH in old people, very common BPH. Okay, stricture in urethra in young age, trauma, urethral and pelvic trauma. And yes, one important thing about the pelvic trauma is that in pelvic trauma, pelvic brim injury or pelvic trauma, what happens in pelvic brim injury or pelvic trauma, there may be bleeding, from artery, there may be bleeding, profuse bleeding. And due to pelvic trauma, due to any reasons, there is outlet obstructed and the urine is not able to pass out. So what happens? So urine is storing inside the bladder, and this filled bladder this filled bladder is pressing the bleeding artery, somewhere bleeding from this artery, and this filled bladder is pressed the artery and acting like a tamponade. There is a tamponading effect. There is a tamponading effect of this bladder, and due to this tamponadic effect, the bleeding is relatively lesser. If you decompress the bladder, so let's imagine you are putting a catheter and trying to decompress the bladder, and sudden decompressions, if you decompress the bladder suddenly, what happens? This tamponading action of the bladder is gone. This tamponading action of the bladder is gone, and the compression effect from the artery is also gone. So sudden decompressions leads to profuse bleeding. Sudden decompression leads to profuse bleeding, and suddenly there may be what? Hypotension. Let's imagine a road traffic accident. Patient comes to your emergency and with acute retention of urine with pelvic brim injury, and what you done? You done the sudden decompression of bladder, and on following, this is you have watched that his BP is falling. Okay, this is due to what? This is due to maybe the bladder this is due to the bladder lost his tamponade effect on the artery, and the bleeding from the artery started profusely. Okay, this is one case. So never decompress the bladder suddenly. Okay, so gradual decompression is important here, not the sudden decompressions. Okay, in case of pelvic brim injury. Now look at this. Yes, this is the causes. Okay, so this is the fact in case of male, female. Okay, so what are the features? Yes. What are the clinical features? Pain on the swelling in the suprapubic region. Let's imagine this is the abdomen. This is the abdomen. Yes, this is the pubic symphysis, and this is the umbilicus. Suprapubic swelling. This is the swelling at this region. Suprapubic swelling at this region. Okay, swelling and pain at this region. Suprapubic swelling and pain at this region, and inability to pass urine. Yes, smooth, soft, tender swelling in the hypogastrium region, which is dull on percussions. On clinical examinations, this swelling, the abdominal swelling, which is smooth and soft and tender. Okay, and on percussing, this is dull node on percussings. Okay, so these things are the clinical features. And parectal examinations, you have to done these parectal examinations, but in full bladder, the parectal examinations, it is not reliable. The result of the parectal examination is not reliable. One thing which I want to add here, yes, normally in parectal examinations, actually, what is parectal examinations? This is the bladder and this is the rectum. Okay, this is the bladder and this is the sagittal view, and bladder is anterior and rectum is posterior. This is the bladder, this is the rectum, and somewhere there is prostate. Okay, and putting your finger into the rectum, you just trying to palpate the mucosa on the prostate. Okay, you just trying to the mucosa on the prostate. Okay, if this mucosa is smooth, mucosa over the prostate is smooth, then generally it is indicating BPH, any benign hypertrophy of the prostate. But if the mucosa on the prostate, if the mucosa on the prostate, mucosa lying on the prostate, this mucosa is irregular, it is irregular, it is irregular, that is something indicating towards the carcinoma. Okay, this is the finding of rectal examinations. Anyways, so now this is done. Okay, so investigations. So first you have to do the USG abdomen. USG abdomen to rule out the prostatic cause or the bladder or the urethric cause. So if prostatic enlargement to specify the prostatic enlargement, or for evaluation of prostatic enlargement, you have to do the USG of kidney, ureter, bladder. So here USG abdomen is a broad term. Okay, USG abdomen is a broad term. So more specifically, for the evaluation of prostatomegaly, you have to go for USG kidney, ureter, bladder. Transrectal USG may be done. Urodynamic study may be done. Okay, especially the post-voidal residue of urine to detect. Next is the serum PSA, that is prostate specific antigen. This is the biochemical test. Okay, and to evaluate any bladder or urethral anomaly, or to evaluate any bladder or urethral cause, you have to do micturating cystourethography and cystoscopy or urethroskopy. Okay, so first of all, don't answer it I have to do this, that is USG KUB, I have to do this micturating cystourethography first. No. First, as an intern, you have to do what? As an undergraduate, you have to do what? The relief of retention. This is the work of your intern or undergraduate. Okay, like you and me. So relieve the retention and then diagnose the cause. This is under diagnosing the cause, and then treat the underlying cause. If this is BPH, then you have to treat the BPH. If this is any bladder or urethral injury or bladder or urethral stricture, you have to do this accordingly. Okay, so you have to manage this accordingly. So now urinary retentions. Do you know the types of urinary retentions? Examiner may ask you. Yes sir, I know the urinary retentions. The types: acute retention, chronic retention, and retention with overflow. So in acute retentions, there is short history. Yes, there may be pain, although in our cases there is no pain, but pain is generally present. Okay, may or may not have palpable bladder. Bladder is not palpable. Actually, why the bladder is palpable? During chronic retention urine, what happens? The bladder wall, it gets thickening of the bladder, and it enlarged and thickening of the bladder. Okay, so that's why it is palpable generally. So in acute case, it is not palpable. Kidney function test. Yes, kidney function test is normal generally in acute case. Next is the management, that is Foley's catheterizations. If Foley's is failed, then suprapubic catheterizations. Next is, what is chronic retention? Chronic retentions are generally the BPH, and this BPH is causing the bladder outlet obstruction. BO means bladder outlet obstructions. Generally chronic cases are painless and palpable bladder, and this palpable bladder, what is the features? The smooth, soft, tender swelling in the hypogastric region, dull on percussions. Already I told you this thing. And the KFT generally deranged. And what is the management? The Foley's catheterizations followed by suprapubic catheterizations if Foley's is not possible, and then gradual decompression of bladder. This thing is important. Otherwise hematuria. Yes, also I told you in pelvic brim injury also the gradual decompression of bladder is important. Otherwise profuse bleeding and hypotensions. Okay, KFT monitored and hydrations maintained. This is the management of this. Okay, so which investigations? Already I told you, and again I am repeating the investigation. First you have to do USG abdomen. USG abdomen is a broad term. Under USG abdomen, to rule out the prostate enlargement or to evaluate the prostatic cause, you have to do this much things, and to evaluate the bladder cause, you have to do this much things. Done. You have to check the blood urea and serum creatinine. Yes, and another biochemical test is also there, that is prostate specific antigen, serum prostate specific antigen. You have to look for this also, and also look for urine microscopy, any to rule out any UTI, any urinary tract infection is there or not. Okay, or any hematuria, etc., etc. So done. This is the case discussion. So relieve, first is relieve the retention, then the diagnose the cause and the treat the underlying cause.